Assalamu alaikum. Let's discuss about hypertrophic cardiomyopathy. It's a very high yield topic for USMLE. In hypertrophic cardiomyopathy, the pathophysiology is genetic mutation affecting the cardiac sarcomere protein. There is genetic mutation affecting these cardiac sarcomere proteins. It is autosomal dominant and variable phenotypic penetrance. So there is variable phenotypic penetrance and it is autosomal dominant. And in hypertrophic cardiomyopathy, the clinical features, it may be asymptomatic. There may be exertional dyspnea, fatigue, angina, lightheadedness, syncope. On clinical feature, there is systolic ejection murmur accentuated by decreased left ventricular volume. So, in hypertrophic cardiomyopathy, there is systolic ejection murmur accentuated by the decreased left ventricular volume, and there may be diastolic dysfunction with audible S4. There is diastolic dysfunction. So hypertrophic and restrictive is diastolic dysfunction. Very high yield in hypertrophic cardiomyopathy, and in restrictive cardiomyopathy there is diastolic dysfunction. An increased risk of atrial fibrillation and ventricular tachycardia. There is increased risk of atrial fibrillation and ventricular tachycardia. Okay, listen to this first. Can you guess this sound? Okay, it is S4, and this audible S4 is found in hypertrophic cardiomyopathy. Okay, how can we diagnose this? On ECG, there is left axis deviation, left axis deviation, and there may be abnormalities of the depolarization. There may be abnormalities of the depolarization, like presence of Q wave or repolarization, that is inverted T wave. On echocardiography, there is septal left ventricular hypertrophy, dynamic left ventricular outflow tract obstruction, dynamic left ventricular outflow tract obstruction, and left atrium dilatation. And there is left atrium is dilated. Okay, if we look at this ECG, there is inverted T wave. Look at this inverted T wave. There is tall R and deep S. So tall R in AVL, and deep S in V3. This is the one criteria like Cornell criteria. So Cornell C, ABC. So in deep S in V3 and in tall R in AVL. And there is repolarization changes in the anterolateral leads 1 AVL V4 5 6. So in lead V4 or 5 6 there is inverted T wave. There is inverted T wave, which is the repolarization changes in the anterolateral lead, in lead 1, AVL, V4, 5, and 6, and there is stall R in AVL and dip S in V3. So if these criteria fits, then it is a hypertrophic cardiomyopathy. Okay, now look at this question. A 24-year-old woman comes to the office due to dyspnea on exertion, fatigue for 2 months, and the patient felt lightheadedness, almost passed out while running on a treadmill. She had recently upper respiratory tract infection for 3 months. Okay, good. Oxygen saturation is normal, JVP normal. A crescendo decrescendo systolic murmur is heard on the left sternal border. A crescendo decrescendo systolic murmur on the left sternal border, without radiation to the neck. No radiation in hypertrophic cardiomyopathy. There is no radiation, and there is rapid upstroke of the peripheral pulses are present. There is carotid pulse has dual upstroke. Or what is the most likely cause of these symptoms? It may be interventricular septal hypertrophy. It may be HCM. In HCM, hypertrophic cardiomyopathy, there is SAM, systolic anterior motion of the systolic anterior motion. So, there is systolic anterior motion, and there is hypertrophy of the interventricular septum. There is hypertrophy of the interventricular septum. If we want to differentiate from aortic stenosis from aortic stenosis and hypertrophic cardiomyopathy. In hypertrophic cardiomyopathy, if you remember this, in hypertrophic cardiomyopathy, if we recall the Valsalva, abrupt standing, and nitroglycerin infusion, nitroglycerin admission, Valsalva strain phase, in Valsalva abrupt standing, and in nitroglycerin, actually what it does, it decreases preload. It decreases preload and it decreases left ventricular blood volume. It decreases preload and it decreases left ventricular blood volume, which will increase the murmur intensity. It will increase the murmur intensity. It will increase the murmur intensity. So in hypertrophic cardiomyopathy, that these three conditions, Valsalva, abrupt standing, and nitroglycerin decrease preload, and it will increase the murmur intensity. Look at here. On the contrary, in aortic stenosis, there is decreased murmur intensity. And in aortic stenosis, there is decreased murmur intensity on decreasing preload. This is the very important point by which we can differentiate aortic stenosis from HCM. So in HCM, decreases preload actually increases murmur intensity, and in aortic stenosis, decreased preload will decrease murmur intensity, and increasing afterload, like on hand grip there is increased afterload, increased left ventricular blood volume, which will decrease the murmur intensity in HCM. It will also decrease the murmur intensity in aortic stenosis. S4 is for hypertrophic cardiomyopathy. S4 can be present in aortic stenosis. Ejection click, very high L. Ejection click is usually present in aortic stenosis. In hypertrophic cardiomyopathy, ejection click is absent. And carotid pulse in soft and delayed aortic stenosis, soft and delayed. But in hypertrophic cardiomyopathy, there is a brisk carotid reflex. In hypertrophic cardiomyopathy, C before C there is B, so brisk carotid pulse is present. Brisk carotid pulse is present. Okay, if we see this question, so in this question, if we read this question, there is this is also hypertrophic cardiomyopathy, and it is seen by there is faint murmur on supine and increases the intensity of murmur while and increases the intensity of the murmur while standing. So we know that Valsalva abrupt standing, we know that Valsalva abrupt standing and leg raising, we know that Valsalva abrupt standing and nitroglycerin, these three conditions, Valsalva abrupt standing and nitroglycerin, these three conditions decrease preload, decrease left ventricular volume, and increase murmur intensity. So standing increases murmur intensity. So standing increases murmur intensity, and there is motion of the mitral valve leaflet towards the septum. septum. There is interventricular septal enlargement. In many cases, systolic anterior motion of the mitral valve and further contributes during ventricular contraction and left ventricular. During ventricular contraction, the anterior mitral valve cusp extends toward the septum of the left ventricular outflow tract. The degree of the left ventricular outflow tract depends on these two. Okay. O- If we look at this question again, 27-year-old syncopal episode after heavy backpack. Okay, no, medical history. There is no family history. Family history is common in hypertrophic cardiomyopathy, and ECG showed T inversion in V4 to V6. So T inversion in V4 to V6. He works in a landscaping. Okay, most important. Blood pressure. There is no orthostatic hypotension. There is only ECG finding, and he got unconscious for a bit uh, after unloading heavy backpack from the truck during a hot summer day, and ECG showed this. So what should be the next step? The echocardiography should be the next step. Why? In echocardiography, we'll find these three findings: left ventricular septal left ventricular hypertrophy dynamic, left ventricular outflow tract obstruction, and left atrial dilatation. Left atrial dilatation. So these patients exertional syncope and ECG shows exertional syncope and ECG shows T inversion in V4 to V6 raised suspicion of hypertrophic cardiomyopathy. Exertional syncope and ECG shows T inversion on V4 to V6. Think about cardiomyopathy. Think about hypertrophic cardiomyopathy. The systolic murmur characteristics of the hypertrophic cardiomyopathy is sometimes absent. The systolic murmur is sometimes absent because the left ventricular outflow tract obstruction may be absent or present with exertion. ECG is usually abnormal and may show left axis deviation or disruption in the depolarization. There may be prominent Q wave, repolarization, T wave, inversion, and syncope due to HCM is usually exertional syncope is present, which will reduce cardiac output due to dynamic left ventricular outflow tract obstruction, and exertion related factor dehydration, decreased left ventricular volume lead to low blood volume, which can exacerbate the obstruction and markedly reduce cardiac output. This mechanism likely explains these patients' episodes of exertional lightheadedness, and there may be ischemia-induced ventricular tachycardia. HCM causes increased myocardial oxygen demand and reduced myocardial oxygen supply even at rest. Intense exertion amplify oxygen supply and demand mismatch and can trigger ventricular arrhythmia. Left ventricular uh, outflow tract obstruction can further exacerbate their mechanism. Ventricular arrhythmia does not terminate as it does with syncope and is the typical cause of sudden cardiac death in HCM. So ventricular arrhythmia is a typical cause of sudden cardiac death in HCM. If we look at this question, 6 months old chest pain, okay, medical history is bronchial asthma. There is S4 found in HCM. There is systolic murmur at the left sternal border. Systolic murmur, left sternal border. ECG show LVH. LVH criteria. LVH is found in HCM. Echocardiography show left ventricular hypertrophy, asymmetrical septal hypertrophy. Left ventricular hypertrophy, asymmetric septal hypertrophy. Coronary angiography reveals no evidence of atherosclerosis. Coronary angiography reveals no evidence of atherosclerosis. Which of the following is the most appropriate pharmacotherapy for this patient? We can give beta blocker or non-dihydropyridine calcium channel blocker. We cannot give these drugs AC inhibitor and nitrate. Okay, so in medication in negative chronotropy and negative ionotropy benefit. So negative chronotropy, force of contraction, and negative chronotropic and negative ionotropic benefit by increasing left ventricular volume in the following ways. So negative chronotropy means decrease. Chronotropic effects actually means the heart rate, it may be increased or decreased. As it is negative chronotropy, so decrease heart rate. So negative chronotropy slows the heart rate to increase left ventricular volume and left ventricular and diastolic volume. And negative ionotropy reduces the ventricular contractility to allow the systolic ejection to complete a higher left ventricular volume and increase left ventricular systolic blood volume. Beta blockers is the first line therapy, but they cannot be given in asthma. So we are choosing non-dihydropyridine calcium channel blocker. Verapamil diltiazem to decrease the chronotropy and ionotropy to decrease the chronotropy and the ionotropy. Okay, if we look at this question, this 17-year-old, okay, ECG show normal sinus rhythm T inversion in lead. There is T inversion in lead V5, V6. There is left ventricular hypertrophy impaired, early diastolic filling, and mild left atrial enlargement. So left atrial enlargement, ECG T inversion, and there is left ventricular hypertrophy, looks like HOCM. So in HCM, there is left atrial size is increased, left ventricular cavity size is decreased, left ventricular wall thickness is increased more than 15, left ventricular diastolic function is impaired. Okay, if we look at this final question where 40-year obstructive cardiomyopathy scheduled for elective hysterectomy, okay, mild dyspnea, she takes metoprolol, blood pressure is 120 by 80, examination show clear lungs. Which of the following recommend to prevent perioperative complication? So perioperative complication, ensuring adequate IV hydration. So we know that in the degree of the left ventricular outflow tract obstruction is worsened by low blood volume, low left ventricular blood volume, and thereby hemodynamics should be optimized to encourage the left ventricular blood volume throughout the cardiac cycle, both in diastole and in systole. High left ventricular and diastolic volume, high preload encouraged by adequate hydration and avoidance of venous dilator like nitroglycerin. Avoidance of venous dilator like nitroglycerin maintained relatively low heart rate is beneficial as it lengthens the diastolic filling to increase the end diastolic volume. And high left ventricular end diastolic volume is encouraged by relatively low stroke volume. A relatively low stroke volume, whether from low contractility or from high afterload, leads to blood being ejected at a higher left ventricular blood volume. These higher left ventricular blood volume minimizes left ventricular outflow tract obstruction, allowing more effective cardiac output. In contrast, in if in systolic volume gets too low, there is precipitous drop in stroke volume, leading to severe left ventricular outflow tract obstruction. Okay, so if we look at this question, so family history present, there is 3 by 6 mid systolic murmur. So S4 is present. So we should give beta blocker or non-dihydropyridine calcium channel blocker. If we look at this question, this is the family history and we diagnose it as a hypertrophic cardiomyopathy with this, looking at this murmur, this 3 by 6 ejection type systolic murmur. And this is the very high yield question. This is also hypertrophic cardiomyopathy. There is carotid pulse, has dual upstroke. There is apical impulse. Oh, the most important part in here, like faint mid-systolic murmur based heart at the cardiac apex along the left sternal border, and which maneuver actually increase the murmur intensity. Then Valsalva abrupt sending and nitroglycerin. These three will decrease preload, decrease left ventricular volume, and increase the murmur intensity. So that is all about hypertrophic cardiomyopathy. It's a very important topic. Hope you enjoyed.